just let people know I don't have any financial ties to any of the companies that produce the devices that I use in my practice. This will include brief mention of a couple of off-label uses of technologies that are FDA approved. And in the Q&A, we may end up getting into technologies that aren't FDA approved in the US yet, but mostly we'll stick to the stuff that is on label and FDA approved. And we'll blow through some of this stuff to save time at the end. Suffice to say, about a third of patients who have epilepsy will still have seizures despite everybody's best attempts at medical management, okay? Of this piece of pie represents only the patients who are not controlled on medication, so patients who are still having at least one seizure a year on meds, okay? And this is the number of them that actually make it to a surgical therapy. Okay, so we estimate the population in 2000, and these numbers have changed a little bit, but nobody's really done a comprehensive look at this yet. There were probably about 61,000 new diagnoses a year and up to 500,000 people walking around with an epilepsy that was potentially amenable to surgery, and about 2,000 surgeries a year were happening. Okay, so possibly one of the most underutilized procedures in all of medicine. 10 quick misconceptions that are probably preventing people from being referred to epilepsy centers. The idea that before you're a surgical candidate, before we declare that your surgery has been medically refractory, you have to try all the drugs that are out there. No. Okay, we know that by the time you're on your third medication, the likelihood that you are going to get to seizure control by adding a new drug is probably less than 5%, assuming that your epileptologist hasn't been just picking drugs out of a hat. And, given how good most epileptologists are these days, the likelihood is that they've had a rational reason for choosing the drugs that they've chosen. And if you're on your third medication and still having seizures, the likelihood that additional medical therapy is going to get you seizure-free is less than 5%, okay? If you have abnormalities on your EEG coming from both sides of the brain, you're not a surgical candidate. That's not true. Okay, there are a lot of people who have an abnormality on one side of the brain, seizures arising from one side of the brain that have epileptiform or abnormal electrical activity on both sides of the brain is high enough that it still deserves a workup, okay? A normal MRI means you can't have surgery. MRI is good. It's getting better. I mean, compared to what we used to have, it's a phenomenal technology, but it still doesn't tell us the whole story. There may be a very specific area of the brain responsible for seizures that we don't see on MRI, that we need other methods to detect. So just because the MRI is normal doesn't mean there's not a surgical option, okay? Conversely, if you have multiple areas of MRI abnormality, we can't help you because there's just too many problems. Well, maybe you have multiple abnormalities, but the vast majority of the seizures, or even all of the seizures, are coming from only one of them. Maybe we can address that area without having to worry about the other problems. I tell patients, in sort of multiple areas of my practice, we're not here to try and make your scans normal. We're trying to restore your function to as close to normal as possible. So it doesn't really so much matter about, having multiple areas of the MRI involved. Surgery isn't possible if what we call primary cortex or a strongly functional area of the brain is involved. Well, we actually have a lot more options than we used to. Surgery will make your memory worse if you've already got a memory problem. Not always. If you remember Dr. Jensen's talk, the keynote address this morning, she talked about how there are network issues at play here. One bad area of the brain, by constantly generating seizures or seizure-type activity, can disrupt the function of areas of the brain that are very remote from it. So a lot of times, even if we're taking out an area of the brain, things may not get any worse because that area already wasn't working. Sometimes things can even get better because that area may have been interfering with other areas of the brain that are supposed to be doing their job and can't when the bad information from the epileptogenic area is being fed into them, okay? Severe cognitive or behavioral problems are contraindications to surgery? No, not necessarily. We can still potentially improve function. Patients with focal epilepsy and a focal lesion can have the lesion removed without a detailed pre-surgical workup. This is the opposite. I mean, these myths that we've been talking about are barriers to surgery. This myth is an important area to consider because it says, well, you can just sort of refer somebody to a neurosurgeon who's not in an epilepsy center, and they can say, okay, you've got an abnormality here, you've got epilepsy, let's take the abnormality out, you're going to get better. No, you can't do it that way. You still need to go through the evaluation pathway that we're going to talk about. Okay, surgery is unsafe and expensive compared with medical management. Well, that's true if you have somebody who is being successfully managed with medications. If you're on a seizure medication and you are seizure-free on that medication and you're having acceptable side effect profiles, then that is safer than surgery. If you're still having seizures, despite best medical management, your risk of serious injury or death as a result of your epilepsy is significantly higher than the risks associated with epilepsy surgery. Okay? We're not just talking about SUDEP, or sudden unexplained death in epilepsy, right, which can happen to people who are having seizures. We're talking about, being in the bathtub at the wrong time. We're talking about being at the top of a flight of stairs at the wrong time. We're talking about, I have a patient that I saw recently that we were working up for epilepsy surgery, and there were some delays related to hesitation on his part, and unfortunately, we're now set back quite a ways because he had a seizure that was so violent that it fractured, dislocated 2 of his limbs. And we're getting him back from that before we look at surgery. Okay? And then only surgical candidates need to be referred to epilepsy centers. This is a chicken and egg problem here, right? Who's a surgical candidate? Somebody who would benefit from surgery. How do we know somebody could benefit from surgery? Because we've done the full epilepsy center workup, right? So the folks at comprehensive epilepsy centers are at the front lines of what can be successfully treated with surgery, right? There are a lot of very, very good community epileptologists out there who are going to manage very well the patients who are going to get control with medications. They're up on the latest pharmacotherapy. They're up on the latest trials as far as what drugs to give, okay? But for those patients who are still having seizures despite best medical management, they need to be seen at a comprehensive epilepsy center. They need to have at least an evaluation for surgical workup, for device implantation, for some of the other options that are available, because the needle keeps moving as far as who is a potential candidate. So to have somebody who's sitting out there thinking, well, I shouldn't go to a surgery center or a comprehensive epilepsy center because I'm not a candidate for surgery based on what I've read, that may not be true anymore. And in fact, I'd argue that people who told that they weren't a surgical candidate 15, 20 years ago, maybe even 10 years ago, should revisit the question, because the scope of what we can do has changed. And that's what this talk is about, how the technologies have changed that. So successful epilepsy surgery has 2 components, broadly speaking. Localization of the epileptogenic zone. The epileptogenic zone is the area of the brain that's necessary and sufficient to generate a seizure. Otherwise put, it's the area of the brain that if you took it out would cure the epilepsy. Okay? That's what the epileptogenic zone is. And then, can we safely disrupt the epileptogenic zone without disrupting other normal functions? Like Dr. Jansen said, a lot of times the area of the brain or the network involved in generating seizures has a day job, right? How important is that day job? And is that area of the brain still doing it, or has it given up its day job to focus on generating seizures, right? Some areas of the brain just say, I'm enjoying this seizure gig so much, this is all I'm going to do now. Other areas of the brain actually sort of stick with that day job, and then the question becomes, can we disrupt the seizure generation without making it so that whatever that function is can't be performed, okay? And then when we talk about disrupting, that used to mean go in and remove it, right? Scalpel, what we call a bipolar coagulator, suction, remove that area of the brain. That's still a mainstay of our therapy, but nowadays we have, and we'll look at, precise destruction of tissue by laser, by focused ultrasound, by radiation, or in cases where we are worried about surgical destruction of tissue, can we functionally disrupt that area using electrical stimulation? Okay, so localization of the epileptogenic zone, right? So the important part is that not all epilepsies have an epileptogenic zone. So we talk about generalized versus focal epilepsy, right? When we're talking about a generalized epilepsy, what we're talking about is typically a problem in a channel on the surface of a neuron or of the support cells, something that is responsible for those cells being hyperexcitable, okay? And that's in the DNA, it's in every cell involved. And so there's really no way to focally disrupt that, and those really are best managed by medication, or there is one option that we'll talk about in a little bit, which is one form of stimulation, okay? But you can't localize the epileptogenic zone because it's not local. There isn't a specific abnormality in a part of the brain that's responsible for the seizures. In contrast, focal or localization-related epilepsy, you have an area of abnormality that's the problem. There's a bad actor somewhere in the brain. It could be because of a malformation in the brain, could be because of a previous infection, a head trauma, a stroke. All kinds of different things can cause an area of the brain to become responsible for generating seizures. But the question is, where is that area? Okay? And it's not as simple, as we said, as looking at an MRI and seeing there's an abnormality, because a lot of times the abnormality is not one and the same with the area that's generating the seizures. Then we have to localize which areas of the brain are still doing important jobs. Jobs like movement, jobs like visual processing, jobs like language processing, right? And we have our standard maps of the brain going back, 60, 70 years to the initial mapping studies. But the problem is, if you have a network disruption in your brain, particularly if you've had it since childhood, and we learned from Dr. Jensen how plastic or sort of remodelable the brain is, well then, your brain may not correspond to this map, right? Your functions may have moved. And we have to know, for you, the individual who's being evaluated for epilepsy surgery, what does your functional map of the brain look like? How is it different? So, how we start, right? And the first thing is just, what are your seizures like? What we call the seizure semiology is what happens when you have a seizure. What's it like, right? Do you, for example, start to smell something abnormal? Do you have what we call an aura, where you get a feeling, a rising in the stomach, a strange sensation, something that typically tells you, I'm about to have a seizure, okay? Because those, depending on the nature of the aura, depending on how frequently you have it, can give us a clue. Does one side of your body start shaking before the other? Are you still able to understand even as part of your body is shaking, or are you sort of disconnected? What we call, are you having a complex seizure where consciousness, interaction with the outside world is disrupted? All of these things can be clues. Okay? The surface EEG is the workhorse as far as figuring out where the seizures seem to be coming from. But the surface EEG has a limitation, and there's an analogy I like to use, which is pretend that this room is the skull, okay? And pretend that the windows are blacked out and you have somebody standing outside the room with their ear pressed up to the wall. So they can probably hear enough to tell that there's a lecture going on in here, and they can probably make out some of what the lecture's about. But and usually, to make this point, if I weren't being videotaped, I'd be wandering around the room and asking you, do you think they can tell you right now where I am, right? Who's talking, what's up on the slide projector, right? All of those things are off limits because the skull and the scalp just do too much to attenuate the electrical signal. MRI, again, fantastic tool, constantly evolving. Magnet strengths are getting better, the tricks we can do with it are getting better, but it still does not tell us nearly the whole story. And then neuropsychological testing is an important part of figuring out how has epilepsy disrupted the network function in the brain. Are there neuropsychological problems? Are there the kinds of changes that are often associated with an abnormality of one part of the brain or another? Can it give us a clue as to where the seizures are coming from, which side of the brain? Can it give us a clue as to what memory function is likely to be like after surgery? So it's an important part of things, okay? But ultimately, for localizing where the seizures are coming from, in many cases, we can't answer the question from outside of the room. Okay? Some cases we can. There's something called mesial temporal sclerosis. It's actually a very common kind of epilepsy, although we see it much less because we're so good at picking it out now that most of the time the people who have it, we get the MRI, we see it, we see that the seizures are coming from the proper side, we do the surface EEG, we do the neuropsychological testing, and then we say, okay, your mesial temporal structures, your hippocampus and your amygdala, and depending on the patient, possibly some more of your temporal lobe, need to be removed. And that's that. Well, that's gotten much less common. Now it's usually questions that are more complicated, and the way that we used to have to answer those complicated questions, I apologize if anybody's squeamish, but I sort of like to make a point with this slide, which is that this is what a lot of people think about when they think about epilepsy surgery. Okay, so to go back to our room analogy for a moment, this is basically the equivalent of finding out what's going on in this room from outside the room by knocking down this whole wall. Okay, so this, up until about 10, 15 years ago, was the best thing we had, and that was we made an incision like this on the scalp. We removed a large piece of the skull, and then we put these grids and strips of electrodes down over the surface of the brain, sewed things back up, and put them in the epilepsy monitoring unit for a week to 2 weeks, and watched the seizures evolve, and did stimulation mapping off of those electrode contacts. We still do this occasionally, okay, but you can see that this is an approach that lacks finesse, for want of a better description, okay? You know, if we can avoid knocking down the wall, if we don't have to specifically do this to answer this question, if we don't have to leave patients with a large scar and potentially some muscle atrophy on the side of their head that can be cosmetically very undesirable, if we don't have to do those things, just to get an answer to the question, even, can we remove your epileptogenic zone? Is it safe? Can we find it with this? Because imagine going through all this and then being told, well, you're not actually a candidate for surgery, right? Now, we can do some neat things with all this information, believe me. So this shows where the seizures show up on the surface first. This shows where we stimulate and get function of the hand, stimulate and get function of the face. This is an area of prominent what we call interictal abnormality. Okay, so we're getting very good at rendering the information that we get from those grids. And there are still cases that they're indicated, but I'll tell you, they're very few and far between. I don't put many of these in anymore. This is what is called stereo EEG, or stereo electroencephalography, okay? Each of these, and they're not as big as they sort of look on this X-ray, the metallic artifact makes them look bigger than they really are, but each of these is a thin wire with 12 electrode contacts, okay? And basically with a little nick on the skin, about this big, a hole in the skull that's about this big, we can put these wires into the brain and have the tip of the wire be where we wanted it to be within about 1 to 1.5 millimeters. Okay, so very precise placement, deep into brain tissue, and in a way that is non-disruptive. Okay, and we can make grids. So these are just a couple of sort of the grid arrays that we've created using stereo EEG, where we're basically catching broad swaths of the deep areas of the brain that we couldn't get with surface EEG. So not only is this less invasive than smacking those big grids down on the surface of the brain, it actually lets us explore areas of the brain that were off limits with the grids. I mean, there's no way to safely get down to these areas of the frontal lobe with a grid, okay? I mean, yes, you can do it, but safely, no. And you can see we create these patterns of mapping that, again, we go back to our reconstruction, and this is where the seizures are rising. These oranges are where there's heavy interictal activity. Here's another case where, you know, for pediatric patients, these are so much better than the grids. So this is a girl where this is what we call the interictal, and the yellows are where we see some abnormalities. The orange is first on sort of the densest problems. The red is where we see an actual lesion on the scan. And then during the seizure, we can actually look and see where the seizure onset is, where it spreads to. And we can map those areas by stimulation just at the bedside. Even less invasive than stereo EEG. Every electrical current generates a magnetic field. And the converse is partly true. A magnetic field can generate an electrical current, provided that it has the appropriate target, that there's something that's conductive in the right plane relative to the field. Okay, but every electrical current generates a magnetic field. And this device, which is called a MEG, magnetoencephalography, can actually look at the relative activity of the magnetic field and pick out areas that are excitable or abnormal. And if we go back to our room analogy and we think about SEEG as sort of drilling a series of small holes in the wall and putting up like a little fiber optic camera to those holes, for this now we're starting to talk about some kind of scanner that you can use through the wall. So we haven't disrupted the wall at all. Now it has significant limitations, so think about that scanner technology as being sort of crude. It can maybe we can pick out, like in some of those SWAT team movies, how many people in the room, but not who they are. But still, relative to what we had before, this is much more sensitive than surface EEG as far as picking up what's going on. Now again, we're talking about epilepsy being an issue of networks and also about wanting to map out where functional brain is before we think about how to proceed with a surgical workup. This is the flip side of MEG, and this is one of the areas that I am most excited about, not just for epilepsy, but for treatment of a whole range of neurosurgical disorders. What this does is, we just said, right, currents generate magnetic fields, and magnetic fields can generate currents. Well, the transcranial magnetic stimulator generates a magnetic field in the proper plane relative to the brain tissue to generate electrical currents in the brain through the skull in a very precise fashion by using very focused magnetic fields. It can excite an area of the brain that is smaller in resolution than a square centimeter. Okay, and we can do all kinds of things to monitor what that does. We can put wires on the arms and legs and actually detect which muscles are responsive below the threshold where people even feel their muscles moving. So put an RTMS up to somebody's head, generate a magnetic field. The patient doesn't feel anything, but a wire in the contralateral arm might pick up an electrical current that says you are specifically stimulating this part of the arm as a result of that magnetic field. And the best part is we can actually put up an MRI on this screen right here, match it to the patient's face using basically a surface rendering model to capture with an infrared camera what the patient's face looks like, and then put the stimulator over the brain and map where on the actual surface of the brain to within an area of precision that is analogous to what we'd get if we actually took off the skull and started putting an electrical stimulator on the brain surface. What happens when you excite that part of the brain? So for mapping, for networking, this is going to be a major emerging technology, and it's actually also used to treat some disorders. Treatment of epilepsy with this is not here yet, but it's probably coming. One of the neat things about TMS now is that you can actually use TMS in a way that doesn't disrupt EEG electrodes. So we can put an EEG on you, use the TMS to stimulate areas of the brain, and then actually see what the electrical response of other areas of the brain is. So now we're really looking at the networks. The other way we can look at the networks is diffusion tensor tractography. So this is an MRI protocol that is relatively new, relatively 5, 6, 7 years since it's really been sort of diffusely available. But what it does is it looks at the different ways that water molecules behave when they're traveling along a nerve versus outside of a nerve. Okay, and it uses those differences in the properties of water molecules to generate maps of the fiber bundles. Now these are just pretty maps because this is basically taking the whole brain and using it as a seed area, and that's not particularly useful unless you want to show people sort of how complex the fiber bundles in the brain are. But what can be much more interesting is to say, I'm going to select a specific area that's related to an abnormality or to a brain function that I want to preserve, and I'm going to follow those fibers within the 3D model of the brain that I've created in my imaging. And I can compare. For example, what does the fiber network on this side of the brain versus this side of the brain look like? And in this case, you can tell that there's a very clear difference, right? There's been significant disruption in this network relative to the normal network on the other side. You can also do things like saying, okay, I'm concerned about preserving speech, and I have used TMS to map out where the speech centers on the brain are, but where do they connect to? What do the circuits look like? Using the areas where you have found speech function in the brain, you can actually feed that to your MRI scan. Say, I want you to go back, take these areas of the brain and find out what's connected to them, and you can do that with the scan. You don't even have to have the patient in the scanner. You can just generate the data set during one MRI and then go back to it as many times as you want and say, I want to use this area of the brain as my seed. What fibers are connected to that area of the brain? You can see how that would be, yes?
So basically this is getting you, you're going to see exactly what it's going to affect, and then you decide about the surgery, if it's worth it, if it's going to affect something major that you don't want to possibly. I'm trying to break it down so I can understand.
Yep, absolutely. So this is one of the tools we can use. Direct mapping using the SEEG is one of the tools we can use. But the idea is we're trying to come at those two separate questions. One, where are the seizures coming from? Two, what is the relationship of that area to the functional areas of the brain that we want to preserve? And so that's how these sort of interrelate with that. That's exactly right. Okay. Now, when we've identified the area, now what do we do about it? Well, it used to be you had to go in there and take it out. Now we actually have something called MR thermometry coupled to laser interstitial ablation. What that means is we can put in a laser probe. We can put the patient in an MRI, and we can actually use an MRI protocol that relative to the tissue around it tells us what the temperature of the brain tissue around the laser is. Okay, so you fire the laser and you can actually watch the heating happen in real time. And when the heating reaches the threshold that you want, the threshold that you know is associated with destruction of tissue, you stop firing the laser, snap cool the brain by using nitrogen, and you have just ablated only the tissue that you want to destroy without destroying the other area tissue around it. Now this uses a laser probe. We're actually learning how to use focused ultrasound. So we don't even need to put a probe into the brain. We can have several ultrasound generators that basically cause the molecules to vibrate using sound waves, and where those waves come together, they cause so much vibration that the molecules start to heat up. Okay, so these are ways that we're learning how to destroy tissue without actually having to open up the skull. Finally, neuromodulation for folks that aren't any kind of tissue ablation candidates. If we can't get rid of an area of the brain, can we alter its electrical function? Okay, so the most common form of neuromodulation for epilepsy is still vagus nerve stimulation. Okay, and the vagus nerve is a tract that has a lot to do in terms of inhibition of excitability in the brain. VNS is very imprecise, but for people who aren't attaining proper control with medication or who are having unacceptable medication side effects, it can be an important alternative. And we're getting more sophisticated about applying it, and we're getting more sophisticated about potential ways to screen for it. So the problem is right now, we don't know how VNS is going to affect somebody. We just implant it and hope. Particularly in patients who aren't candidate for other forms of modulation. As we get more sophisticated, I believe that we're going to be able to do a better job of picking out non-invasively who's going to respond, particularly by doing what we call transcutaneous stimulation. So basically stimulators that stimulate through the neck tissue. for a period of time. And the people who are good responders to that, we know they'll probably respond even better to having the stimulator implanted. The people who don't respond to that, maybe we need to look for something else. So I think that'll be a way to really get at the heart of the big problem with VNS so far, which has been knowing who's going to respond properly to it before you put them through an expensive and somewhat invasive operation. I mean, relative to some of the stuff I've shown you, it's much less invasive. It's a small incision in the neck, a small incision on the chest, but still, any surgery has potential risks. So if we can know who's going to benefit from it, that's going to help us apply it in both a safer and more cost-effective manner. RNS is different from VNS in the sense that it has to be focused towards a specific area of the brain. We still have to do the localization. With VNS, we don't have to know where the seizures are coming from. We just have to know that we haven't controlled them with medications and we don't have another option. For RNS, if we know where the seizures are coming from and there's a reason why we can't take it out, what this can do is you have one electrode here that is monitoring the electrical function of the brain. You have another electrode here that's going to stimulate. And this very complex but very compact processor can learn to recognize when it looks like a seizure is brewing and basically shoot an electrical impulse into the part of the brain that's trying to generate the seizure and disrupt seizure formation before it can spread. And this is what that looks like. You have the brain just kind of doing its thing, then you have epileptiform activity starting, and then the processor recognizes it and fires and aborts the seizure activity before it can get going, right? This is the epileptiform activity. This is the brain after this has fired and before the seizure has had a chance to spread and cause problems. This is a young technology, but an extremely promising technology. And this is just what it looks like. Because of electrical insulation and the need for rapid responsiveness, this has to be implanted in the skull. But it actually sits down in the bone. So cosmetically, it's actually very nice. We can put it into the skull itself so that it's not sticking up out of the scalp. This is another area of active research, and when I said I wasn't going to talk about stuff that was FDA off-label for the most part, this is what I was referring to. Deep brain stimulation is not currently FDA approved for epilepsy, but it is FDA approved for a host of other disorders, and there's very active research about how to use it for epilepsy. Looking at different anatomic targets. One of them is the anterior nucleus of the thalamus. The other is looking at the subthalamic nucleus. The fornix is an area that I've done some research in, but before we get too far behind. To summarize, around a third of epilepsy patients will continue to have seizures despite trying multiple different drugs. Many of them may be candidates for ablation or resection, which can be curative. And that depends on how long you've had epilepsy, how dysfunctional the network has become as a result of uncontrolled seizures. The sooner we get to a patient, the better, okay? Because we talked about how the brain learns, and Dr. Jensen talked about how the brain learns how to seize. The problem is that if you start out with one bad area, that bad area can teach other areas of the brain how to become epileptogenic all on their own. And so at some point, we lose the ability to cure somebody because too many areas of the brain have become implicated in this pattern of dysfunctional activity. New technologies are just expanding at an unbelievable rate. We talked about diffusion tensor tractography, we talked about TMS, we talked about focused ultrasound. One of the things about focused ultrasound is that it actually may let us knock out the function of areas of the brain without permanently disrupting them. So with the laser, you put the laser in, you burn an area. Hopefully you've already tested that area with an electrode to see if it's going to cause a problem. With focused ultrasound, we may be able to do the screening and the destruction at the same time. So set it to low, disrupt an area of the brain, see what happens to the patient. If nothing happens, if they're still sitting there going, okay, doc, when are you going to start actually scrambling things?
Then they get up and can't walk. They try to get
Well, no, so that's the point. We do motor screening, we do sensory screening, we look for all of the possible functional disruptions before doing the lesioning. Okay? So surgical resections are becoming more focused and less invasive. In some cases, we can ablate it using laser therapy, focused ultrasound therapy, potentially radiation therapy. And patients who are not candidates for a cure may be candidates for neuromodulation, for RNS, for VNS, for things that still require sort of long-term maintenance. I mean, batteries need to be changed or recharged, parameters need to be checked and reprogrammed, but at least we're doing something that can be, more effective or with fewer side effects than medication. And then we said for neuromodulation right now, RNS, VNS, both FDA approved for the indication. DBS, not yet FDA approved, but an active area of research.
Have you had a lot of success with VNS?
So, our success with VNS has been very comparable to the national experience, which is that it is not a cure, but for patients who do not have other alternatives, it can be a real game changer. And I'll tell you, one of the things that used to hold us back a little bit about VNS was the question of, if we put in the VNS, are we going to preclude being able to do a better workup down the road as MRI technology approves, et cetera? But most VNS, so all VNS that we're implanting now is what we call MRI conditional, meaning that as long as you properly set it before going into the MRI, and as long as you use the proper MRI protocols, you can still get an MRI with a VNS in place. And so that means it doesn't preclude, further stuff down the road. So I think it's a technology that unfortunately at some period was, like many medical technologies, being applied in a sort of scattershot fashion. People were sort of throwing up their hands and saying, well, we don't know what to do, so put in a VNS. And that gave the technology, I think, a worse name than it deserved. I think it has a clear role, and its role will probably get better defined as we get, as I said, better at screening people to find out who is most likely to benefit. So again, it's a tool in the arsenal, and there are definitely good uses for it. Yeah.
So you sort of half answered my question with your comment about how, the sooner things are dealt with, the better. But really my question is, with how fast things are changing, with how much new technology there is, I'm working myself on the screenings and the testing and whatnot, but I definitely find myself going, well, are there going to be, infinitely better options in 5 years, 10 years from now, with how fast things are changing?
Almost certainly.
Yeah.
Almost certainly there are going to be better options in 5 years. And the problem is that if you have uncontrolled seizures, your chance of dying is a multiple higher than the general population. So do you want to wait around for something that we think is coming down the pipe, understanding that what we've got now is already very good and could not only improve quality of life but actually save your life? Obviously I have a bias, but my answer is medical technology will always get better. But that doesn't mean you wait for that to happen to affect a positive change now, at least to finish the workup and hear about the options, because again, the morbidity and mortality associated with uncontrolled epilepsy is greater than anybody except the types of folks in this room can understand. I mean, people who haven't experienced it don't understand what a disruptive force it is, and that's why I was so honored to be asked to come and talk to the Epilepsy Exchange, because I love being able to have conversations like this, and it's not the people in this room that we need to tell some of this stuff to. It's the broader population. Epilepsy Awareness Month is right around the corner. I see people in their purple. I'm loving it. But get the message out, and don't wait for the next good thing. Don't wait for the blockbuster drug that's going to cure epilepsy. At least get the workup, hear about your options, and understand that unfortunately, I talked about the patient who had the seizure that literally broke both of his arms from the violence of the seizure. I have a patient who we were looking at for something called a corpus callosotomy, which we didn't even address here, but it's a disconnection procedure for people who have drop attacks and who don't have another option. We disconnect the two halves of the brain so that at least if one side is seizing, the other side is not going to catch the seizure. And it changes some things, but not as profoundly as you might think, and it stops people whose seizure pattern is a drop attack. Well, before I got to operate on this guy for his drop seizures, I had to operate for his subdural hematoma because he had a drop attack at the top of a set of stairs, right? I mean, this happens. This really happens. We have people that we are trying to move forward with for evaluation for epilepsy surgery, and then instead they're in the trauma ward. So, first of all, when I have patients come into my office and they're not scared of surgery, I don't call neurology, I call psychiatry. Okay? Second of all, there is no such thing as minor surgery, except the definition of minor surgery is surgery being done on somebody else. Okay? A surgery on you is a major surgery. And when it comes down to brain surgery, that's a big deal. I will tell you, and hopefully not get in any trouble for this from the corporate people at Temple, that I have the utmost respect for Dr. Sharam and his entire team at Jefferson, really, you know, all of the major institutions in this city. I mean, it's just fantastic to be here practicing again after going to med school. The same thing was true when I was in Cleveland. There are a lot of people doing really good work, really devoted to what they're doing. It's right for you to be apprehensive. It's right for you to want to know as much as you can about the risks and benefits of the operation. But I don't think there's anybody in this city that I know of that is being irresponsible or loose with their indications for surgery. Okay? When they say this is the operation that we would recommend, that recommendation comes from a significant body of experience and a genuine desire to help. Okay? I mean, if you wanted to talk to me about back surgery, maybe we'd have a different conversation about the financial pressures. But the fact of the matter is, for all of its warts, I don't think there's anything in the American healthcare delivery system right now that inappropriately incentivizes people to do epilepsy surgery, right? So the system works the way it's supposed to. Surgery really is, in cases where the workup has been properly done, typically the best option. Okay, now that doesn't mean that it's without risk or that it's not going to have potential consequences, and that's where your conversation with the doctors there is so important. Okay, pre-surgical counseling. I mean, people think that the surgery is the hardest part of what I do, but I would say, you know, in a lot of ways, it's the pre-surgical counseling. It's the sitting down with people, trying to understand their values, their concerns, trying to explain to them in their terms what the likely impact of the surgery is going to be. And that can take a long time, right? And the key is, again, you don't want it to take too long because you don't know what could happen. Epilepsy is, so everybody knows what a brain aneurysm is. You've all heard about them. Uncontrolled epilepsy is as dangerous as having a brain aneurysm. Okay? We don't think about it that way, but when you look at the statistics, it absolutely is, right? And people don't hesitate. I mean, the big problem with brain aneurysms is we find out that somebody has one, and then they come in and they say, I want surgery. I want you to clip my aneurysm. Well, your aneurysm is actually, it's only about 3 millimeters by 3 millimeters. It's on an area of the circulation where it's really not. No, I want you to clip my aneurysm. You know, they don't like the idea of a ticking time bomb. But that's what uncontrolled epilepsy is. We just haven't sort of realized the extent to which that's true. And so I really strongly encourage you, don't let that fear get the best of you. Go in there, have the conversations, understand that these people are there to take care of you, to help you, and that they will do their absolute best to make sure you come through it with the best possible outcome.